Thank you again. Seriously, thank you for coming. This is great turnout, and I'm happy to talk really about anything. But kind of the point of tonight's is going to be hip and knee pain. So, like Nicole was saying, I did a dual fellowship. I did fellowships in both orthopedic trauma, and I also did a fellowship in hip and knee replacement. So a little bit about me. I grew up in Burlington, Vermont. Was there for undergrad and medical school, and then I went to Durham, North Carolina, where I did my residency at Duke University. And then after Duke, I left and went to Tampa, Florida to do my trauma fellowship, and then Salt Lake City to do my hip and knee replacement fellowship. So I did a little bit of subspecialty extra training in both those areas. So I'm basically 100% a trauma surgeon and 100% a joint replacement surgeon. So that's kind of my daily life and a little bit of background on me. So like I said, we'll talk about hip and knee pain, specifically arthritis, but not only arthritis, and then a little bit on hip and knee replacement, kind of what to expect, a little bit on the recent technology advances and things like that. So osteoarthritis, this is the big problem, okay? This is the wear and tear arthritis, estimated at 40 million folks in America by 2020. So that's only next year. We're looking at 40 million people with osteoarthritis. So it is a relatively big problem. Significant burden, so all races are affected equally. We see a little bit more on the women's side than men after 50, but then most of us kind of by our 60s and 70s are afflicted a little bit with either radiographic or clinical evidence of osteoarthritis. And when I say osteoarthritis, I'm talking wear and tear arthritis. There are multiple different types of arthritis. Folks have heard of rheumatoid arthritis. That's probably the biggest inflammatory condition. So it's a little bit different. Osteoarthritis is really just wear and tear. And that affects the major joints primarily. So we're talking hips, knees, and shoulders. It can affect every other joint in the body, including the spine. And then more of the inflammatory arthritis conditions we think of more in the fingers, the elbows, toes, things like that. But getting down to basics, so you say, what is a joint? Well, in the simplest of terms, a joint is just where two bones come together, lined with cartilage, and they're going to articulate or move on each other. So my elbow, my shoulder, my knee, my hip, or whatnot. The reason I like this picture is because I get a good analogy out of it. So if you consider this being the bone here, and then the cartilage tread like a tire, when that tire wears out, just like anything else that wear and tear occurs, you get this breakdown. That breakdown of cartilage is going to lead to a couple of different things: exposed bone, inflammatory cells. Your knee gets angry, it fills with fluid. And when that knee fills with fluid, that's the pain you have, that really aching sensation. It feels like you're bending your knee against a water balloon. Those are all symptoms, and you can kind of relate it to this analogy of a tire, really losing the tread on the tire. Here's a cartoon illustration of kind of what that looks like. Here's normal cartilage appearing here in a little spot area of arthritic change. And then this is more of a advanced change where you have this exposed bone. You've got the menisci here with degenerative tears, and it's just a bone grinding on bone. And if we look at that inside the knee joint, you actually take some, when we do arthroscopic procedures with little cameras, make tiny incisions and look inside. I know lighting is not perfect for this, but this is the femur. This is the tibia. And then this big triangle here is what a meniscus looks like when it's normal and healthy. Fast forward to an advanced arthritic knee. You have the cartilage that's frayed, the bone. So when people talk about bone-on-bone arthritis, that's what we're talking about. So this bone here is exposed. There's no bumper left. So when you're walking around, that bone is just grinding on the rest of the bone. All of this red, irritated, inflamed arthritic tissue is also just stirring up things. The knee doesn't like it, or the hip, shoulder, whatnot. And that's the pain that you're feeling. This is another clinical kind of photo of what a hip joint looks like. So here's the ball, and this is a picture of the cartilage actually being delaminated, ripped right off the bone. That can be obviously incredibly painful. I've never had it myself, but I can tell it's probably very, very uncomfortable. And that's just another picture down there, exposed bone, cartilage being ripped off. So what are the causes? We talked a little bit about the primary arthritis or osteoarthritis. Wear and tear arthritis is the most common form of arthritis that we see in this country. It's not a direct cause of aging, but it's certainly related to the aging process. Multiple different factors kind of lead to the process, including a decreased ability for your cartilage to actually repair itself. So over time, if you twist wrong in your 20s, or if you tear your ACL when you're playing basketball, that's damaging the cartilage, and that cartilage has a decreased ability to repair itself. And so over time, it wears out, and then once that thickness gets down to the bone, there's really nothing left. So that's when you get that bone on bone. The ligaments supporting the joints weaken with age. We know that tends to happen, and also the muscles around the joint tend to weaken. So the best protection for a healthy joint is to keep it moving and keep it strong. So we'll talk a little bit about that as well in terms of prevention. There are other types of arthritis, so secondary types of arthritis. So some folks are born with actual congenitally abnormal joints. You might have heard of something called Perthes disease. It's where the hip joint itself doesn't form correctly because of an abnormal blood supply. Those are all things that can lead to arthritis down the road. And then one thing that I see specifically as a trauma surgeon is joint injury. So if you have a knee fracture or an elbow fracture, shoulder fracture, something like that, we know it increases your risk of developing arthritis later down the road. Weight loss. So weight loss is a huge aspect of this problem. So the one take-home point that I kind of wanted to point out is that for each pound of weight loss, your knee sees 7 pounds less force across it. So you can imagine if you lose even 10 pounds, the knee is seeing 70 less pounds. So it really likes that. So we certainly encourage, obviously, less weight, less load on the knee. One of the common kind of misnomers or terms that get thrown around is osteoarthritis and osteoporosis. So just want to clear that up real quick. Osteoarthritis is not osteoporosis, two separate things. Osteoarthritis is that wear and tear joint destruction, whereas osteoporosis is just a loss of bone density. So in osteoporosis, the bone is actually normal structure. There's just not as much of it. You can see these are the normal spaces that you would see between a bone. And this is how vacuous that bone becomes. It just becomes thinned out and a less volume. So not the same things, osteoporosis and osteoarthritis. Now, what are the symptoms? Well, the symptoms of arthritis typically are the same for most everybody. It's pain. That's the number one cause. Pain when you wake up in the middle of or in the morning. Pain when you go to sleep. Pain when you've been sitting for too long of a period of time. Pain when you're going up and down stairs. These are buzzwords that we hear all the time that says, hey, oh, I got up and I had to shake it out a little bit. My hip, felt like it was seizing up like a joint in a car. Those are things we hear all the time. Stiffness, another one. Folks say, oh, I sit in a chair for too long. I go to the movie theater, I get up and I can't move my knee. I've really got to wear it out a little bit. Those are very common signs. And then this catching or grating sensation. And that physically is just that bone grinding on the bone. It's kind of an unpleasant feeling, but that is actually what is happening. What does the knee or other joints, but a knee specifically, look like in an x-ray with this kind of thing? So this is a normal knee, and it's a little bit blurred with the lighting, but you can see the space between the bones. That's where the cartilage lives. You can't see cartilage on an x-ray, but we know it's there, and that's why the bones aren't touching. When that cartilage wears out and is completely gone, that's what occurs. You have just this bone grinding on the bone, big bone spurs here, big bone spurs there, and then all of this hazy white stuff is your body's reaction to that. So the bone is seeing more force. It's compressing down. It's called sclerosis. So the big three things are loss of joint space, subchondral or underneath the cartilage sclerosis, and then these big bone spurs. And actually bone spurs, so your body, when it has pain, it attempts to limit the movement because it knows let's take your knee, for example, when your knee moves, it hurts. So the body, in an attempt to limit that pain, actually tries to form bone. And that's what a bone spur is. It's actually trying to lock down the joint so it doesn't move anymore. It's kind of an interesting defense mechanism. And if you take this long enough, the bones actually do fuse together. We don't see it very commonly anymore, but that actually does occur. Here's an example of a hip arthritis. So again, it's a ball and socket joint. The space between the bones there is where the cartilage lives, nice, healthy, thick space. That tread is gone. That tire is bald, and those wheels are just rubbing on each other there. So you can imagine how painful that is, and that's why folks have so much pain, discomfort, loss of motion, and inability to do kind of activities of daily living. Here's just another major joint that we see most commonly. It's a shoulder. Shoulder, again, is this ball and socket sort of joint. Space between the two bones there, nice, healthy. No space left. That white subchondral sclerosis, big bone spurs there. That's just your body's attempt to lock that joint in place so it doesn't hurt. Well, what do we do about it? Goals of treatment. The goals of treatment is to make your life better. This, in the end of the day, arthritis is a quality of life problem. It's not cancer, it's not going to kill you, but it affects your quality of life. things you can't do. You can't go to the store. You can't play with your kids and grandkids. You can't get down and walk the dog. You can't, stay sitting down at a presentation like this, listen to me too long without having kind of pain. These are all things that we like to talk about as the goals of treatment. We want to relieve pain, increase motion, and improve strength. I really like this analogy. So I always talk about this kind of ladder approach to treatment. You got to start at the bottom and walk the rungs up. We try to do, or I personally think you should do everything you can non-surgical first before you exhaust everything non-surgical before you start getting to the surgical kind of top rung of the ladder. So what's the first rung? Well, medications. This is the simplest, easiest, first line of defense against arthritic pain. In the end of the day, arthritis is an inflammatory process. It's not necessarily rheumatoid or wear and tear arthritis or post-traumatic arthritis. They're all the same. They're all, your knee or your hip or your shoulder is irritated and angry, it's inflamed, fills up with fluid, and that's going to cause you significant pain. So the best thing to do to limit that amount of inflammation is an anti-inflammatory. So just an over-the-counter ibuprofen, Aleve, Advil, naproxen, these are all the same class of medicines. They're actually phenomenal pain relief medicines. I prescribe them for almost all of the traumas that we see. It's a non-narcotic, non-addictive, tremendous pain medication. And it works because it limits the inflammation. So your body produces all these inflammatory cells when it has an injury or has arthritis. And if you can limit that inflammation, you limit the pain. The problem with these, though, is they're not without their own side effects. Sometimes you can't take them because you have kidney problems, you have stomach problems that make a lot of folks, stomachs upset. So we use them as much as we can, but sometimes we can't use them. Other medicines like Tylenol, they're good, they're just not as good. So we wish we could use these in everybody, but again, they do have their problems. You just need to kind of discuss with your doctor whether or not they're good for you. We're at the next rung of the ladder, and notice I didn't include narcotics because narcotics are they're not good medicines for arthritic pain. They're quick and easy, prescribe them and try them, but the problem is a narcotic just blunts your body's response to pain. It doesn't actually treat the problem, whereas an anti-inflammatory is actually treating the problem of inflammation. It's not curing the disease, but it's limiting the symptoms. So when we skip right up to the next rung after you've tried anti-inflammatory medicines, it's injections. So probably people have heard of cortisone injections, steroid shots, that kind of thing. We use these quite commonly. Cortisone is just a fancy term for a steroid. Depomedrol, Celestone, they're all the same things. But again, their goal is to limit that inflammation. So if you can't take anti-inflammatories or you've been taking them for a real long time and you're just getting your stomach upset, this is a very good option. It's not a cure, but it's a Band-Aid. It's basically like taking a whole bunch of ibuprofen, putting it right in the knee joint or the shoulder or the hip. And the goal is to calm down that inflammation, which is the pain generator. Doesn't cure the disease, doesn't cure arthritis, but it's a temporary patch. The other option are these viscose supplements. So you might have heard of these rooster shots, sometimes people call them. The problem with those is they're very expensive and they haven't been shown to do anything more than a steroid shot, which is like $1.50. So, I'm happy to try them. I think they're great options if you've exhausted everything else. You're either not a candidate for surgery or you want to continue going on without surgery. They're totally reasonable because they don't hurt. The problem is they don't necessarily have a tremendous benefit, but they're part of our ladder approach. They're used and certainly can recommend them. And then joint protection. We talked a little bit about this with the weight loss. So again, 7 pounds for every pound of stress across the knee. So there are some do's and don'ts that we want to talk about here. Daily range of motion exercise is great. Knees, hips, everything. Joints like movement. They respond well to movement and they like to be moved around. The cartilage itself actually reacts well to joint motion. So we really want to make sure we maintain our range of motion. The other thing we like to do is strengthening. So the best protection, like we touched on a little bit before, is keeping the muscles around joints strong. So again, take the knee for example. Getting your quadriceps muscle strong is the best protection before an operation and after an operation. It allows your patella to track appropriately, or your kneecap goes up and down instead of shifting side to side. It provides stability to the joint. So if you see if I'm walking here and my knee's giving out because my muscles are weakened or my joints are weakened, you can see how that would cause significant pain because that's grinding that bone on bone even more. So really is a strengthening around the knee and hip and whatnot are very, very important. And then endurance exercises, again, that's more geared towards the weight loss aspect of it, but it's a low impact aerobic exercise is what we really would like to see. So that's pool therapy, recumbent bike, kind of that hard pound running is not what we really prefer if you can not. So exercise do's, we talked a little bit about this. You want to talk to people who can give you some advice at first as to what to do with your physical therapist or a physician. One thing that we commonly see is people try to do very, very deep, again, take the knee, deep knee flexion activities. The knee does not like deep flexion, especially when it's arthritic and painful. Bracing. Bracing is, I think, can be pretty beneficial. It's, again, non-operative treatment, relatively inexpensive. My favorite is actually just these little over-the-counter neoprene sleeves. They do a couple of different things for you. Number one, they provide a little bit of compression, so they can help with the knee swelling. And again, when the knee swells, it's painful, so you limit that swelling, it feels better. Actually can improve your balance a little bit. So there's something called proprioception. So proprioception is your body's ability to know where you are in space. So for example, if I close my eyes, I know where my hand is because of my proprioception. So all joints like proprioception as well. It keeps them going straight rather than doing these kind of shift movements. So the brace actually provides a little bit of feedback loop to your brain, especially with proprioception. So you can improve your balance. And it gives you a little bit of that swelling control, and they're super easy to use. There are some more kind of involved, to say, braces. This is called an unloader brace. I don't know if anybody's heard of one of those before. So a lot of times the knee, again, I use the knee, it's very common, but the knee, you can have arthritis on the inside of the knee and maybe a preserved outside of the knee. And so what that brace does, it actually kicks your leg into a little bit of valgus, unloads the inside of the knee and puts more of the force on the intact cartilage. They work to a degree, but the problem is they're incredibly poor compliance. They're bulky, they're hard to put on, they're a little bit painful, and they're like $500 or something like that. So they're a little bit more tricky to get folks to use and kind of really get the benefits of. I have not found them to be as beneficial even really as just a neoprene sleeve, to be honest with you. But again, these are all things we think about trying to avoid surgery. And I know that's crazy for a surgeon to say that, but we are trying to get as much life out of the normal joints as we can. We've tried braces, we've tried sleeves. Now we're talking about even external support aids. So canes, walkers, crutches. Again, their goal is to unload the joint. So you're actually, take the hip, for example. If you have hip arthritis or pain, you have a cane in the opposite hand, you're actually increasing the lever arm and taking the joint reaction forces off your hip by walking with the opposite hand crutch or cane. And so they can be helpful. But again, these are Band-Aids, they're temporary, they're patches, they're not cures. We've reached the top of the ladder. We've tried medicines, we've tried injections, we've tried physical therapy and braces. What do we do when all else fails to relieve the pain? We've reached the top of the ladder. We're talking surgery. So first thing you want to think about when you talk about surgery is you got to ask questions. You want to be involved with the decision. You want to discuss what are the alternatives. What are the benefits? What is the rate of success? What are the risks? There are risks involved to all surgeries. They can be low, they can be high depending on what the procedure is. And they can also be low and high depending on what medical conditions you may or may not have, what sort of surgeries you've had in the past. And then you want to know what the expectations are. That's probably the number one thing I would say. What is the expectation of surgery? Some people come in and say, my knee hurts. I want to be able to run a marathon again. Not the operation for a total knee replacement. If you say, my knee hurts, I can't sit on the ground with my grandkids. I can't go to the store. My knee swells up when I try to walk my dog. That's a perfect expectation for a knee replacement. It's different. That's a conversation you have to have. Here are kind of some x-ray pictures of what joint replacement looks like. So here's a total knee replacement, meaning you replace all of the parts. Here's partial knees. This is an inside partial, an outside partial. And then this is what a hip replacement looks like. These are the parts involved with arthroplasty or joint replacement. This is the the femoral cap. This is the tibial tray. And this is the piece of polyethylene plastic that the femur articulates on. So that's how you bend your knee. In the hip, here's the replacement of the socket. Here's the replacement of the ball. And then there's that piece of plastic again where they articulate. So a lot of people come in and say, what is a knee replacement? Do you take my knee and throw it away and, put in some robotic something or other? It's actually a lot less involved than that if you think. What we do is we go in and we make very precise, fine cuts and remove all of the diseased kind of arthritic portions of the cartilage and the exposed bone and all the soft tissues that are bothering you, and just replace it with a cap, almost like a crown that a dentist puts on. You are literally just shaving off the bad parts, putting a metal cap on. We do the same thing in the shin or the tibia bone. Same thing, we shave off that diseased cartilage that's worn through, and we put this metal cap on, and there's a piece of plastic. You keep your muscles, you keep your ligaments, you keep all the soft tissues all around. So it's not a knee, throw it in the garbage, put a new knee in. It's literally just a resurfacing. So we're taking that tire, that tread, you're going in and you're getting it redone. Here's a little bit of just a plastic model kind of showing you how we make those precise fine cuts. This is a representation of your ligaments, so your ligaments all stay. We hook these up with very precise, or with a lot of precision. We make these very fine cuts all throughout the bones on both sides using these supplied jigs. And then they're capped off and either cemented on or press fit, so a very tight fit, and then the bone actually grows into the prosthesis. One of the things we commonly hear, even from the primary care physicians who are sending patients our way, is, well, they have terrible hip arthritis, but they're 82. And we didn't think they were eligible anymore because they're, too old or whatever. It's actually not true at all. This is a study that came out of Duke, where I did my residency training. They showed seniors with arthritis who undergo hip replacement are twice as likely to show improvements in functioning and ability to care for themselves. And the most important thing they highlighted was no age limit on the benefits. So it's a discussion you need to have. Of course, risks, benefits. There are certain things that we can discuss, that are age appropriate, but it's not a contraindication. Meaning, it's not a, well, here's my age cutoff. We're not doing it anymore. So it's one really important thing to remember. How about new technologies? There's always new technologies. Everybody hears about things in the news and things we're talking about here and there. One thing there's a couple of different things that I do specifically. It's a little bit of a difference. One is actually just with the approach to the knee. So the traditional approach is we make an anterior midline incision through the skin down to the quadriceps tendon, which is here, and the patella tendon, which is here. And then the incision actually goes in through the quadriceps tendon, wraps around the patella, and comes down there. That's called a parapatellar incision. It's very common. We use it quite often. But there's another relatively smaller, less invasive kind of, I think, a little bit better incision that you can do. It's called a subvastus incision. So a little bit smaller of a skin incision, but really the benefit is instead of going through the muscle, I come over to the side, I release the muscle off the intermuscular membrane so there's no muscle split or cut, move the muscle over, do the work, and then put the muscle back down. So it's a nice little way to keep your quadriceps muscles nice and strong, and limits the amount of rehab you need afterwards, and the recovery seems to be a little bit quicker. So this is what a knee looks like when we open it up. That's all just exposed bone. There's no cartilage left. That's kind of what the cartilage normally looks like. That's just exposed bone. And this is what I'm talking about. So this is me actually retracting the muscle itself over. Gets great exposure. We do all of our work, and then the muscle just flips right back down and close up and be done. So it's quite a nice little advance. May have heard a little bit about robotic technology. So one of my partners, Dr. Sastry, is a huge robotic user. He's a great surgeon. He's a great guy, and so I'm very happy to have joined him. And me and him we're getting along great. So this Stryker is the brand name, Stryker Mako. But what this robotic technology is, it's twofold. So number one, we actually take a image with a CT scan first. And so we use that CT scan. This is me here actually looking at that pre-op CT scan where we've mapped the bone. And so we go in, after we take the CT scan, we go in and we make little measurements all throughout the knee with a little probe. The computer picks up all those measurements, verifies that the CT scan actually looks like the human anatomy that we're seeing. And then once it does that, we actually implant into the computer where we want to make our cuts. So we say, well, we know we want to take 3 millimeters off this part and 2 millimeters off this part. And we put that into the computer. We map it like I'm doing here. We map it on the bone. And then the robotic arm comes in and we perform the surgery. But what the robotic arm does, it allows us to make those precision cuts. So I'm actually holding the saw, pressing the saw, moving everything. But if I were to try to go, way to the left, the robotic arm would stop you. So it's robotic assisted surgery. It's not the robot doing the operation. It's not, me drinking coffee over there while the robot's doing the thing. It's we're doing the operation, but it kind of keeps you in this little tractor beam sort of thing. It doesn't allow you to deviate from what your preoperative plan was. So it's quite a nice little advance. We don't do it on everybody, or I don't do it on everybody. But it certainly is an option, and it's a nice little way of doing hips and knees, really. Here's another cool kind of trick. This is a computer, what we call computer navigation. So this is a jig we've hooked up to a knee. We're measuring where the hip center is and where the knee center is, and then from that we can make a determination of where I want to make my cut and how much flexion is going to be, what the alignment is going to be. Looking at this way, it's called varus valgus. But it's a nice little pocket size, kind of almost an iPhone, that tells us where we're going to make our cuts. So it's another kind of cool little technology that can help in certain circumstances. I use it actually quite often when we're doing post-traumatic cases. So if somebody, let's say, has a femoral rod, or somebody got fixed and you can't access the top of the bone, it's a very neat getaway that you don't need to get inside the bone because there's something already there. Anterior total hip, in full disclosure, I do anterior total hips. I also do posterior total hips. I do kind of every approach to the hip, really. Everybody's a little bit different, so you just have that conversation with folks as to what the best operation for them will be. But there are special tables that we use that help us. And this is kind of what an actual setup looks like. So here's the anesthesiologist who's making sure you're not feeling anything. Here's an assistant. And then the surgeon would be standing over here accessing the hip on that table, and all of this clear plastic is sterile. So nothing in here all of this is all completely sterile and is part of the operation. And there's the hip. That's how we would enter the hip joint. Just one quick thing about consumer beware. So we run into this a lot in medicine. With medicine, you see all those commercials on TV. You're watching the football game, you get a commercial for this pill, this operation, that operation. It's a little bit of, we've done a little research, especially in hip and knee, as hip and knee surgeons, we've done a little research looking at the impact of direct-to-consumer advertising. There's been a very big push for the words minimally invasive. Well, yeah, I challenge you and say, well, what is your minimally invasive? Is that if my incision is 6 inches long, is a minimally invasive 5? Is a minimally invasive 7? It's a little bit of a game that's being played a little bit, so you beware that not everything is right for everybody. So anterior hips, again, full disclosure, I do anterior hips. I love them. I think they're great operations. Not for everybody. There are certain contraindications for having that sort of approach. Posterior approach to the hip has been done for 50 years with phenomenal results. They can be very, very good for people. So it's always a conversation you want to have with your surgeon to decide what the best option is for you, and then also what the risks are and what the benefits are. And then you kind of make your decision from there. So just quickly, some conclusions. Non-operative treatment measures for arthritis remain the mainstay. We do everything we can, or should do everything we can non-operatively before we talk about surgery. It's a ladder approach. It's a continuum. This is a relationship you should be having with your surgeon and being involved in the discussion of where to go. Not too old. That's another big thing. So don't think, well, I should have had this done 5 years ago and now I can't do it. It's a conversation you should have for sure. There are new techniques. There are new surgical techniques. There's new implants. There are new ways to do things. But just beware and have a conversation. Don't be blindsided, I guess, with one thing or another, because there's always risks and benefits to every alternative, really.